The cardiovascular case for niacin is, in terms of documented human evidence, one of the more remarkable stories in the history of nutritional pharmacology. And it's a story that has been systematically buried by a combination of trial design controversies, statin industry dominance, and the newer supplement industry's interest in positioning its products as more sophisticated alternatives. But the core clinical reality has not changed. Niacin at therapeutic doses does things to the lipid profile that NR and NMN demonstrably do not. For anyone managing cardiovascular risk alongside longevity goals, this distinction matters enormously. At doses ranging from 1 to 3 grams daily, niacin produces a lipid impact that no other non-pharmaceutical compound reliably matches. It reduces LDL cholesterol by 10 to 20%, raises HDL by 15 to 35%, and lowers triglycerides meaningfully. These effects are not speculative. They're documented across decades of clinical trials and have been reproduced consistently enough to support niacin's use as a prescription medication for decades. HDL elevation in particular is something niacin achieves better than almost any other available intervention, pharmaceutical or nutritional. Given that low HDL is an independent cardiovascular risk factor, this is not a minor clinical point. NR and NMN have been tested for lipid effects in human trials. They show nothing measurable. This isn't a gap in research that future studies are likely to close. The mechanism for lipid modification through niacin involves its GPR109A receptor activity and its effects on free fatty acid release from adipose tissue, pathways that NR and NMN simply don't engage. They're not inadequate at lipid modification, they're absent from that conversation entirely. Someone taking NMN for longevity benefits and believing they're also getting cardiovascular lipid protection is operating on a false assumption. The AMHI and HPS2 THRIVE trials, which were published in 2011 and 2014 respectively, significantly damaged niacin's clinical reputation. Both found that adding niacin to statin therapy didn't reduce cardiovascular events compared to statin alone. These results were widely interpreted as showing niacin doesn't work for heart disease. But the interpretation requires context. These trials were asking a specific question: does niacin add benefit on top of statins, not whether niacin works as monotherapy? In populations whose LDL was already aggressively controlled by statins, the additional lipid lowering from niacin had less room to produce measurable benefit. The trials were also criticized for their design and endpoint selection. Niacin as monotherapy for patients who cannot tolerate statins, who prefer nutritional approaches, or whose primary deficit is low HDL rather than high LDL, has a different evidence picture. And as a molecule that simultaneously boosts ND+, modulates inflammation through GPR109A, and improves the lipid profile, niacin offers a breadth of cardiovascular relevant effects that no other single compound in this space approaches.